Well, good morning, everybody. Thank you for joining us today for this PAME webinar on sleep, night, and SUDEP. I'm Gordon Buchanan from the University of Iowa, and we put this together today to try to highlight this very important factor of why a lot of SUDEP happens at night. And I'm just going to briefly introduce Dr. Franck Kalume from the Seattle Children's, who's going to introduce our session today, and then we'll get started. So Franck, take it away.
All right. Well, thank you and welcome everyone to our webinar this morning, or whatever time it is from where you are. And it's a great pleasure for us to be with you and share this information about SUDEP, sleep, and circadian rhythm. I am gonna bring up my slide. And before I begin, I would like to thank the PAME for helping us organize this session. And it's a great pleasure to have everyone together. And thank you very much to Anne in particular for all her valiant efforts to put this meeting together. And I hope this will be a wonderful meeting and we'll have a very fruitful exchange and exciting exchange on information about this. As a way of introduction, I am gonna give a little brief historical perspective of our theme today. And for most of you on the call today, you know that SUDEP is a devastating outcome of epilepsy. And it is the most common category of death for people with intractable epilepsy, especially in those with cognitive impairment as comorbidity. And we know from very early 1900 that sleep, night, and epilepsy and SUDEP have a very good, strong correlation. And this is illustrated in this example that I put up here in this slide. And this is showing one of the first witnessed SUDEP case in the world from historical perspective. And this is one of the best well-documented death. And it is the death of Prince John of the United Kingdom. This is the son of King George V, who died in 1919, just about 14 years old. And he passed away from SUDEP, and here's the picture showing him. And when we look at the report from the family doctor, he wrote that Prince John, who has since infancy suffered from epilepsy fit, which have lately become more frequent and severe, passed away in his sleep following an attack this afternoon at Sandringham. And I outline here sleep and afternoon just to show how even in this very early report in 1900, there was already Dr. Alan Reeve Menby already showed that there is an interaction between sleep, the time of the day, and SUDEP. And between that incident and our contemporary times, we know that a lot of investigators have reported that SUDEP occur at night and when the patient is in bed. And this association, and there was always an association in most of the cases here that nighttime occurrence and being in bed was illustrative or indicative of the person being asleep. And in the example on the left here that I'm showing on my slide is part of data from the Mortimus study. And this is a landmark study in the field of epilepsy. And here investigators shows that out of 16 cases of SUDEP that they found in data from epilepsy monitoring units, from many countries in Europe, Israel, and Australia, and many other countries. There was the majority out of 16 here, 14 cases happen at night. And also when they look at these 10 cases of the ones that they had monitoring data, they found that 7 of them occur during sleep, and only a few cases occur at night. And this is very interesting because a new and more recent study, just a few years ago, from the SUDEP North American registry showed that about the same level of SUDEP occur during sleep. And this is based on data that were from medical recording, family interviews, and death reports. So besides all this good association that has been established for many years, and of course for 2 centuries, as you can see, there remain a lot of aspects of this tripartite relationship that are not very well known. And also the role of sleep and circadian rhythm in the pathophysiology of SUDEP remains still not fully understood. And so today our speakers and our esteemed speakers will take us through 4 presentations and to bring to us the new advances in this field of SUDEP and sleep and circadian rhythm. And we'll start our presentation with Dr. Torbjörn from Karolinska, who will speak about why is SUDEP more common at night from a clinical perspective. And we'll have Dr. Roland Thijs, from the Stichting Epilepsy Center in Nederland. We will talk about SUDEP and circadian rhythms. This will be followed by Dr. Kristina Simeone from Creighton University. We will talk about sleep deficiency and SUDEP. And last but not least will be Dr. Gordon Buchanan from the University of Iowa, who will speak about circadian influences on the pathophysiology of SUDEP from a basic science perspective. After all this presentation, we'll have time to discuss the data, and we'll have a question and answer session at the end. So welcome again to our PAME, PAME webinar on the SUDEP and sleep. I'll pass the mic to Dr. Tomson now.
I need you to allow me to share screen.
Oh, okay, I think you should have, and okay.
Now
it's good.
Okay, thank you very much. Thank you for giving me this opportunity to discuss if SUDEP is more common at night and during sleep, and if so, why. These are my disclosures. I intend to first convince you what most of you already know, that the incidence of SUDEP is higher during nighttime and during sleep than other times of the day. I would then discuss the importance of nocturnal tonic-clonic seizures as a risk factor for SUDEP. And finally, I will discuss some possible reasons why SUDEP is more common at night and during sleep. Although it was already discussed by Dr. Kalume, I'd like to start by going back to the Mortimer's study, because this is the source where we have the most precise information about the real timing of the SUDEP event. And as most of you are aware of, the Mortimer's analyzed data from video EEG and cardiorespiratory data from SUDEP cases occurring while monitoring in epilepsy monitoring units around the world. In all SUDEPs, they followed in early postictal phase after a focal to bilateral tonic-clonic seizure. And the course of events were interpreted as early postictal, centrally mediated, severe alteration in respiratory and cardiac function, as has been discussed just a few minutes ago. But the most important part for our discussion is that 9 of the identified cases under monitoring were in prone position at the time of the event, and I will come back to that later in my talk. And also, as mentioned before, out of 11 monitored SUDEP cases, 9 occurred during nighttime, and in fact, the other actually occurred in the evening. There were 5 additional SUDEPs in the EMU that were not monitored at the time of the event, but all of these also occurred at night. So it's clear from the Mortimer study that SUDEP in most cases is a nighttime event. Further support for this comes from epidemiological data, including the North American SUDEP registry. What I show here is to the left data from our population-based Swedish case series of SUDEP cases. We looked at the time of death among SUDEP cases in blue and compared to time of death of other causes of death among epilepsy patients from the same study population. And you see a clear difference in the pattern where SUDEP cases died more frequently during nighttime compared to the other causes of death. Now, nighttime is not exactly the same as sleep. To the right, you see an attempt in a meta-analysis to look at the relation between sleep time and awake time and the risk of SUDEP. The authors collected 880 SUDEP cases, and they found that in 60% of the cases, SUDEP occurred during presumed sleep. So SUDEP was significantly associated with sleep. Now, knowing that SUDEP in the vast majority of cases is a seizure-related event and that it tends to occur during nighttime, the next question that follows is if nocturnal seizures are more harmful than seizures that occur during daytime. This question was addressed in this case control study from the UK with 154 SUDEP cases and more than 600 controls. The authors looked at seizure patterns and divided them into 2. There were those with a diurnal pattern, meaning seizures exclusively during daytime. And then there was another pattern, nocturnal, with seizures exclusively during nighttime. And it was clear that those who died in SUDEP had a different pattern with more nocturnal seizure patterns compared to those control epilepsy patients. So nocturnal seizures was an independent risk factor in this analysis. We also looked at nocturnal seizures as a risk factor for SUDEP in our Swedish case control study. And we found that nocturnal tonic-clonic seizures indeed was a risk factor. If we looked at patients with a history of nocturnal tonic-clonic seizures, these patients had an 8 to 9-fold increased risk of SUDEP. If we looked at patients with a more recent nocturnal tonic-clonic seizure, the risk increase was even higher, 13 to 15-fold increased risk among those patients. So the question is then, why nocturnal and sleep-related seizures are associated with an increased SUDEP risk? It could, of course, be that circadian rhythms contribute to the fact that nocturnal seizures are more harmful. I will not discuss that. That will be discussed in subsequent talks during the webinar. Another question is if sleep itself makes nocturnal seizures more harmful, or if there are circumstances surrounding nocturnal seizures that facilitate the development of SUDEP. This could be being in a prone position in bed, thus complicating respiration. It could be that nocturnal seizures are more frequently unwitnessed, thus limiting the chances for an early intervention. Prone position is frequent in SUDEP cases in general, but even more so in SUDEP cases that occur during night or sleep. Again, to the left, you see our Swedish case series, where nighttime SUDEPs are in blue and not nighttime are in orange. And you see that nighttime SUDEP cases are more frequently associated with being found in a prone position. And to the right, you see the meta-analysis I mentioned before. Again, very similar pattern. Those SUDEPs that occur during sleep are much more frequently associated with a prone position. So it's clearly overrepresented at the time of SUDEP death, and in particular among those with a nocturnal time of death. And of course, it's easy to imagine that a prone position could compromise breathing and in that way facilitate SUDEP. And it has been discussed in an analogy with sudden infant death syndrome if sleeping prone position is a risk factor. However, this might not be the case when it comes to SUDEP. If we go back again to the Mortimer study, there were 9 cases that were found dead in the prone position. However, in 7 of these 9 cases, the patients were not in a prone position at the onset of the seizure. It was the seizure semiology that turned them into a prone position. A related question has been whether a concomitant sleep apnea disorder is associated with an increased risk of SUDEP. So we recently analyzed this using our Swedish case control data, and we did not find any indication of sleep apnea being a risk factor for SUDEP. Another feature of nocturnal SUDEPs is that they are much more likely to be unwitnessed compared to daytime SUDEP cases. And this is again illustrated with our Swedish data, where you can see that those SUDEPs that occur during nighttime are unwitnessed to a very, very large extent. And being unwitnessed probably means also that you don't have much opportunities for intervention. So we think this could be important. And we were interested to see if there was an interaction between poorly controlled tonic-clonic seizures and living conditions reflecting the opportunity to witness the SUDEP case. So in the upper row here, you see cases, patients sharing household and bedroom, and you see that those with uncontrolled tonic-clonic seizures had a 16 to 20-fold increased risk of SUDEP. However, if the patients did not share bedroom but shared household, the risk associated with poorly controlled tonic-clonic seizures was doubled. And if you have patients not even sharing household, the risk associated with uncontrolled tonic-clonic seizures again doubled. This is in line with early observations from the UK case control study, showing that sharing bedroom was associated with a reduced risk to 40% compared to no supervision at all. The reduction was even larger by 90% if special precautions for regular checks throughout the night or listening devices, special supervising precautions during nighttime were available. And further support for the importance of supervision during nighttime can be derived from this study from the Netherlands. It looked at SUDEP occurrence in two different centers for residential care for people with epilepsy and intellectual disabilities. The two centers differed in the level of nighttime supervision. One center, Center 1, had a higher level of nighttime supervision compared to Center 2. And interestingly, the incidence of SUDEP in the center with the higher level of nighttime supervision was significantly lower, 2.2 per 1,000 patient years, compared to in the center with less intense nighttime supervision, where the incidence was 6.1 per 1,000 patient years. It's tempting then to assume that nighttime supervision and a close supervision is enabling an early intervention which may reverse the evolution to SUDEP. I go back again to the Mortimer study because I think the observations there were of relevance for these thoughts. As I mentioned, there were 11 monitored SUDEP cases, 9 of which occurred during nighttime. Among those, cardiopulmonary resuscitation was initiated after more than 13 minutes in all, so that was late. Among the 5 additional SUDEP cases that were not monitored, as I mentioned, all occurred at night, and in none was a cardiopulmonary resuscitation initiated in any reasonable time. In contrast, there were 9 so-called near SUDEP cases, which are patients that have a cardiorespiratory shutdown but survive after resuscitation. In 3 of these near SUDEP cases occurred at night, but cardiopulmonary resuscitation was initiated within 3 minutes in all 7 cases for which this was known. So much earlier than in those cases that actually went into a completed SUDEP. So these are my conclusions. SUDEP is more common at night and during sleep than otherwise. Nocturnal tonic-clonic seizures is a major SUDEP risk factor. SUDEP, and in particular nocturnal SUDEP and nocturnal seizures, are associated with prone position. They are in most cases unwitnessed, meaning missed opportunities for timely interventions that may revert the cardiorespiratory arrest and the impending SUDEP. This highlights the need for improved nighttime supervision of high-risk patients. And with that, I thank you very much for your kind attention.
Thank you. Thank you very much, Dr. Tomson. And then we'll go to our second talk, which is by Dr. Thijs, and it's on SUDEP and circadian rhythms.
Thank you, Dr. Kalume. It's a pleasure to talk more about SUDEP and circadian rhythms and the clinical evidence. And the circadian rhythm is a topic that is where we learn more and more about. And we learned that the cycles are crucial in the timing of seizures. And they may be a 24-hour cycle, 24-hour cycle, daily, weekly, monthly, or even years. So in this respect, it is of importance to have a look at SUDEP and circadian aspects. But if we move to SUDEP, the situation becomes more difficult. We only have a kind of fragmented view. In the ideal world, we would have a lot of recordings of fatal seizures in SUDEP cases, and a lot of recordings in non-fatal seizures and non-SUDEP controls. And we would love to have all the assessments there of the time of the day, sleep stage, and periodical physiology. But the reality is that this amount of recordings is only limited, and we are not fully informed about all these important variables. So in reality, we mainly derive our knowledge from the non-fatal seizures in SUDEP cases and compare them with non-fatal seizures and non-SUDEP controls, or we even step towards interictal markers. And we try to do as much as recordings as possible of time of day, sleep stage, and periodical physiology. But in reality, if you look at the literature, not all studies incorporate all these three aspects. So let's have a look now. I would like to split the talk in two aspects. So start with the circadian cycle and then step to the multidian cycle. So as alluded by Dr. Tomson, there's a clear scenario related to SUDEP, the nocturnality. It's mostly unwitnessed and mostly prone, and very important to emphasize these factors interact. So presumed sleep-related SUDEP cases are more likely to be found prone. And there's also an interaction between sleep and nocturnal sleep-related SUDEP and being alone and having no witness. So when we look at nocturnality and SUDEP, we can establish the coupling with the environmental factors. And then the next question will be, what do we know about the physiological factors? When we compare seizures from sleep versus seizures from wake, then we can note an increased propensity to develop hypoxia or post-ictal bradypnea or tachycardia. Here we see some graphs of three seizure types. At the left, focal aware seizures. In the middle, focal seizures with impaired awareness, and at the right, tonic-clonic seizures with a focal onset. And for all three seizure types, you see that the bars of sleep-related seizures are higher, meaning that the heart rate has a higher increase during the sleep-related seizures. When we step towards HRV, issues become more complicated. There are some studies that compared clock times and night to day HRV in people with refractory epilepsy and found that the night to day HRV is lower in those with refractory epilepsy compared to healthy controls. The same is illustrated in these graphs, summarizing main HRV variables, and in all the HRV variables in the black dots, the epilepsy patients with epilepsy display lower night values. So overall, their night to day ratio was lower. But the issue here is that if you study clock times, you would ideally also need to study sleep. Here in this graph, again, summarizing the results of four main HRV parameters, you see that the depth of the sleep clearly exerts an influence on the autonomic control. So the deeper the sleep, the lower the heart rate, and the deeper the sleep, the lower the sympathovagal balance. And if we now summarize both aspects, the aspects of the clock and the aspects of the sleep, then you see how both variables interact. So there is a clear clock time. So it really matters at what time the HRV is being measured, but as well, sleep stage matters as well. You see the various colors of the sleep stages, and for the same line are contrasting. So if you would record clock time at HRV at 4 o'clock, it wouldn't matter whether someone is in light sleep or in deep sleep. So ideally, a study should incorporate both aspects, so clock time and sleep depth. What do we know about HRV and SUDEP and the circadian aspects of SUDEP and HRV? This is a small study with only 5 SUDEP cases, all with a sodium channel mutation, and 45 non-SUDEP controls. And overall, the awake HRV was lower. And on a group level, there was no difference in the sleep-related HRV measures. But what appeared individually was that there was a high variability, in the sense that some SUDEP victims had very extreme high sleep to awake HRV measures, whereas others had extreme low values. Complicating matters further is this single case of SUDEP who happened to have multiple assessments over time. 7 months prior to dying from SUDEP, 1 day prior to dying from SUDEP, and at the right 30 minutes prior to dying from SUDEP. And from these bars, summarizing 2 crucial HRV parameters, the high frequency power and the cardiovagal balance, you see that there is an overall increase of these measures over time. So when we want to assess risks, it is a difficulty here that HRV is a dynamic variable and apparently increases prior to the event of SUDEP. What do we know of the multi-dying cycle? We learned a lot about the seasonality in sudden cardiac death, with peaks in the morning, on Monday, and in the winter months. In the Swedish patient registry, an attempt was made to look for this seasonality, and there was some trend towards an increase in summer months and also weekend days. And in the larger US study, this was reassessed, and there happened to be no such summer trends and also no weekend effect. And the same conclusion was drawn in this UK study, so no effect of month or season. In addition, in this study, there was some assessment of the temperature or the lunar phase, but no influence was seen there. So, summarizing the things we know about circadian SUDEP rhythms, there's a clear circadian profile, mainly driven by environmental factors, including being unwitnessed and a prone position. In addition, we have some indirect evidence for sleep-related factors with a propensity for apnea and tachycardia. The topic of HRV mainly raises question marks. And we also notice that other circadian factors, most importantly the neurohumoral factors, are largely understudied yet. Regarding seasonality, we didn't find any clear seasonal pattern in SUDEP. So to conclude, we have a lot to study yet, but this is a very interesting topic.
Thank you very much, Dr. Thijs, for this very insightful review of the data. And we will now go to our third presentation by Dr. Kristina Simeone. We're getting her presentation up. We'll talk about sleep deficiency and SUDEP. Thank you.
All righty. Hi, everyone. It is wonderful to be here today. Thank you very much for inviting me to speak on this topic. I really appreciated the clinical background that we just heard from Dr. Tomson and Dr. Thijs, and some of their data is going to segue really nice into some of the topics that I'm going to be sharing with you today. So today we're going to be talking about sleep deficiency and SUDEP, talking a little bit in the beginning about why it's risky to have seizures during sleep and why that might increase the risk of SUDEP during sleep, and also this notion of sleep deficiency. I have no disclosures. And so, let me move this really quick. So preclinical studies have taught us a lot about seizures and sleep. And they have taught us that, number one, sleep is a risky time for seizures. They've taught us that sleep deficiency is upstream of early mortality. Now, this is outside the field of epilepsy. So I'm just going to briefly review some of this data. Number three, from preclinical studies, we've also learned that sleep deficiency may promote early mortality in SUDEP. And number four, that improving sleep may increase lifespan in patients with epilepsy. All right, so for the first point, so sleep is a risky time for seizures. And so here, what I'm showing are just three different models. So two of these models are SUDEP models. So the first one is the Dravet model, the SCN1A model. The second one is a SUDEP model because all of these animals die suddenly of seizures at different ages. And this is a KCNA1 null model. And the third one is just inducing a seizure in a normal control animal. And so what these studies show us is that in the Dravet model, during non-REM sleep particularly, there's more spontaneous spikes. In the KCNA1 null model, during non-REM sleep and REM sleep, we have an increase in spontaneous seizures during this time when compared to when the animals are awake. And these are the more severe spontaneous seizures. In addition, if you take a normal control animal and you induce a seizure during non-REM or REM sleep, then the seizure tends to be more severe. Whereas when you compare that to a seizure that was induced when the animal was awake. In addition, if you induce a seizure during non-REM or REM sleep, during these two states, respiration can slow even more than if you induce it during wake. EEG suppression is longer, and post-ictal apnea can be longer when you induce the seizures during non-REM or REM sleep. So again, all of this data collectively, and there's a lot more data out there that does support the notion that seizures that happen during sleep are a riskier time for potential physiological consequences that could increase the probability of SUDEP. So that was my first point. Now my second point, so we're going to now transition to another track, and this is looking not necessarily at a seizure happening during sleep. What we're looking at now here is sleep deficiency. And so what I mean by that is something similar to partial chronic sleep deprivation. And this means partial means that you're not getting enough sleep every night. Chronic means it happens multiple nights in a row, sleep deprivation. And so this is an operational definition that I'm going to use the term sleep deficiency to describe. So this is not getting enough sleep for each night for many nights in a row. So this is what most of us live, how most of us live. So sleep deficiency, though, when it's chronic, it can be upstream of early mortality. And so this is outside the field of epilepsy. I have 42 references for clinical and preclinical studies that support this, and I didn't have enough space at the bottom to reference all of them. So if you are interested in any of them, please let me know. But some things that sleep deficiency can promote that is upstream of early mortality include things like cardiovascular problems, arrhythmias, chronic intermittent bradycardia, Sleep deficiency is associated with chronic intermittent hypoxia. And so this is reflective of blood gas instability, which is really a really important aspect associated with SUDEP, is being able to understand where your blood gases are and respond appropriately to them to promote the, a proper recovery when blood gases get into kind of severe or toxic states. Sleep deficiency is also associated with changes in respiration or breathing and breathing problems. It's associated with an increase in apnea. And what I kind of want to take a moment to define here is this isn't just sleep apnea or obstructive sleep apnea. This kind of falls under problems with breathing. And this is just apnea happening both during the day and during the night. And it's not always associated with sleep. Sleep deficiency can also promote autonomic imbalance. And this is actually something really interesting. And we have a lot of preliminary data. A lot of it's not published yet, but it really does support a lot of what Dr. Thijs was just sharing about this autonomic imbalance and this change in the autonomic imbalance the closer you get to SUDEP. In terms of HRV and some other markers, really having dramatic differences between being really far away from SUDEP and then actually being closer to SUDEP. And these were done in some of our preclinical studies. So maybe that's a topic we can talk about at another date. But so here, let's stay in sleep deficiency. So sleep deficiency may promote early mortality in the context of SUDEP. And so we have a couple things that I wanted to share with you in this context. So 2 SUDEP animal models have shown sleep problems. So the SCNA or 1A model, the DRAVE model, and this is from Dr. Kalume's lab in 2015. And that reference I failed to put at the bottom, I apologize. And then the KCNA or KCNA1 null mouse model also. And in these models, we have found things like there's an increase in sleep fragmentation. So they wake up more during periods of rest. It takes longer for them to fall asleep. There is less non-REM sleep. There's less REM sleep. There's problems with the sleep spindles. So all of these point to the fact that 2 animal models that we have of SUDEP have sleep deficiency. Now, there is also a lot of changes in pathophysiology that are listed here, and there's many others that sleep deficiency can cause, both clinically and in animal models. And in the context of SUDEP, this has been looked at in one animal model, the KCNA1 null model. And in that model, when these animals are really young and they are farther away from SUDEP, they have a physiology that resembles wild-type control litter mates. However, the closer they get, the more high risk they get to SUDEP, or the closer they get to SUDEP, you have these other biomarkers that start to become prevalent. So they have chronic intermittent bradycardia appears. They start to have chronic intermittent hypoxia, changes in their breathing, apnea becomes more pronounced, and they do have this autonomic imbalance that we were talking about earlier. So the really neat thing about the really neat thing about these preclinical models is that we can go in and look at the brains to see if there's anything changing, big dramatic changes in the brains that we know is responsible and plays an important role in the sleep-wake cycles. And then if there's any dysfunction in that, then maybe that some of those can be targets to help fix some of the neurobiology that might be above the or promoting sleep deficiency. And maybe downstream that can help prevent physiological changes and postpone longevity. And so next, I just wanted to share 2 quick stories with you and then a couple other brief comments on some of the neurobiology that's upstream of sleep and wake and changes that we've seen in preclinical SUDEP models. So on the left, you can see that this is just a really simple schematic showing that when you're awake, you have certain brain rhythms happening. When you're asleep, you have different brain rhythms happening or dominant during non-REM sleep and REM sleep. Now, what I want you to appreciate is there's a very specific neurobiology that occurs that help promote these brain rhythms. And so there are some brain regions that are more active, for example, during non-REM than during REM and wake. And there's also very important neurobiology that's responsible for inducing non-REM, for switching between non-REM and REM, and for promoting wakefulness. And so one story I wanted to tell you that basic science has taught us in SUDEP models is that we're finding some small changes in the neurobiology that's responsible for sleep architecture. And these might be upstream of some of these sleep deficiencies we were talking about earlier. So one is a GABA story. So each one of these squares is a brain region, And it also has the neurotransmitter or neuropeptide underneath. And if the box in the neurotransmitters and peptides are in bold, that means that they're more active during the state of vigilance. And so here we're just showing GABA. GABA is really important for promoting the non-REM sleep oscillations, slow wave sleep oscillations. And one study has found that in the Dravet model, these GABA interneurons, GABA lives in interneurons, and these GABA interneurons are less excitable. And this causes problems in sleep spindle formation, and it also causes problems with the non-REM slow wave oscillations. And so this might be upstream of reducing and promoting that or reduction of the non-REM sleep and that sleep deficiency in this model. So that's one GABA story. I'd like to share with you another story that kind of looks at sleep from, kind of a flipped perspective. So instead of looking at the neurobiology of sleep, we're now switching and looking at the neurobiology of wake, and that's shown down here in the bottom. And so these are different brain regions that tend to be more active. Again, these are very simplified schematics, but these tend to be more active when you're awake. So one thing we found in the KCNA1 null model is that the very severe seizures propagate down to the lateral hypothalamus. And the lateral hypothalamus is where orexin lives. And so the propagation of seizures is shown with this EEG trace on the left, and the orexin neurons are shown on the right. And so in the lateral hypothalamus, orexin is responsible for waking you up, promoting wakefulness. It sends projections to all the other brain regions to say, hey, we got to get up, we got to focus, we need muscle tone, we need to be able to move our bodies, we need to be able to be attentive. All of those signals start with orexin. And so it's considered a wake promoting neuropeptide. Now, this has also been a target of FDA approved drugs for sleep disorders, because if you can block the wake signal, then you can help promote sleep. And so what we found is that not only are there more orexin neurons in this SUDEP model, but they're also more active. And so this might be contributing to some of those sleep problems that we see in this SUDEP model. So those are just two stories about how neurobiology might be causing some of the sleep problems. And in a little bit, we'll get into whether or not we can target these to improve sleep. But before we get there, I wanted to share a couple other stories on some of the sleep neurobiology. Now, in a completely unrelated avenue of research, we have other groups that are looking at really important neuropeptides and neurotransmitters like the serotonin system by George Richardson's group in the SUDEP field. And then also there are three references that I failed to put down here at the bottom. It is COP from 1993, Porzianato from 2018, and Bendari from 2016. And these studies are looking at norepinephrine and acetylcholine, highlighted here in different brain regions in the locus coeruleus and the pontine region. And these guys are looking at these regions in the context of SIDS and finding dysfunction in the context of SIDS. So between the serotonin studies and these norepinephrine and cholinergic studies, there's dysfunction in these systems. They're looking at these systems in terms of chemosensitivity and chemoresponsiveness, but these systems also play a really important role in promoting and being a part of different states of vigilance. So even though sometimes you're looking at neurobiology through one lens, it may have, your findings may have applicability of regulating other aspects of neurophysiology like sleep-wake states. So when it comes to basic science, as you can see, these are the different brain regions that are activated during these different states of vigilance. There's more brain regions that we need to study, and there's more signals that we need to look at. But real quick, I kind of want to go back to this notion of biomarkers, maybe in looking at sleep deficiency in particular. And so before I go into that, I wanted to share a story about my friend Dawn. So Dawn Martens works at the Charlie Foundation, and she has shared many stories with me about her daughter who has Dravet syndrome. And they have done so many different things and changed different aspects of their lives to adapt their family situation and environment to help reduce the seizures of their daughter with Dravet syndrome. And these include things like changing the diet, thermoregulation, and some other things as well. Now, at the 2018 PAME conference, after I shared some of my data on orexin, and at that time it was preliminary and it's now published, but at the time, after I shared my data, many family members came up to me and said that they noticed changes in their loved ones prior to SUDEP. And after Dawn and I had a couple long discussions, we recognized that none of this data is available to the research community. And so with the help of a medical anthropologist, Dr. Laura Heinemann, and a social scientist, Dr. Pierce Greenberg, Dawn and I, and the two of them went on to develop the SUDEP survey. So we developed this survey. It's a retrospective survey for caretakers of SUDEP victims. So this was inspired by the families who attended and chatted with me from PAME 2018. And this survey asks about eight different endpoints. So one of those endpoints was sleep. And so I'll be sharing some of that preliminary unpublished data with you today. And it asked about 8 different endpoints. And so if caretakers noticed a change, then they could say yes, and then there'd be some follow-up questions. If they didn't notice a change, they could say no, and it would move on to the next endpoint. Now, in the instructions, it was very clear to say, if you respond, no, I did not see a change, or if you respond, I'm not sure, those answers were probably just as important or even more important than the yes, I did notice a change answers, because we don't want to be going down false paths. And so the survey is still active, but we have analyzed the first round of data, and I'll share the sleep data now. So again, these are the caretakers' responses for people that have already passed away of SUDEP. And when we asked them, 117 people responded to the sleep question. Did you see changes or notice changes in sleep prior to SUDEP? And as you can see here, half of them responded no, they didn't notice any changes. But the other half, or just under half, responded yes, they think they did notice changes in sleep prior to SUDEP. And specifically, when we asked a follow-up question as, how soon or prior to SUDEP did you notice these changes? So about half of them said it was about less than 2 months they started to notice changes in sleep. But about half of them also noticed that the changes in sleep started more than 4 months before SUDEP. And these changes were things like not sleeping well at night, taking a long time to fall asleep, waking up a lot in the middle of the night, daytime drowsiness. So this would suggest maybe some sleep deficiency in this cohort. Now, again, these are caretakers that are responding to the survey. It is not a clinical study, so there's not enough responses to conduct statistics. This isn't meant to conduct statistics. This is just meant to gather information. And I think that the data that these caretakers were sharing with us could bring some really important insight into our research. And in particular, in the smaller cohort, for those that notice problems in sleep more than 4 months before, that begs the question that that's a monitorable period of time where there could be potential for intervention. So now let's go back to some of our preclinical studies, and we asked that question. If we monitor sleep within subject and find sleep deficiency and then treat the sleep deficiency, can that increase lifespan? And so we used a couple of things. We used an FDA-approved DORA. So this is a dual orexin receptor antagonist. This blocks that orexin signal that we were talking about earlier, or that wake-promoting signal. And so we found that when we administered the DORA, sleep did improve, and we were able to increase lifespan. Now, in addition, we've also, in a separate cohort, we administered a metabolic therapy, like the ketogenic diet. This has been shown to improve sleep in children with epilepsy. And we found the same thing, that in the metabolic therapy, that sleep was improved and restored, and that also was associated with an increase in lifespan. And these, again, are in our SUDEP model. In addition, we wanted to look at those other changes in physiology that we noticed that occurred prior to death. And what we found is in the cohort that were treated with the DORA, again, we're blocking that orexin signal, we found that a lot of these endpoints were restored. And this is published in this recent paper, the IER paper from 2020. And again, lifespan was increased. And so to conclude, these data suggest that targeting biomarkers when they appear may increase lifespan. This has been shown to work in preclinical studies. More preclinical studies need to be done to verify whether these biomarkers exist in other models of SUDEP. But if we can find biomarkers, then perhaps we can target them proactively and use these as treatment strategies to postpone SUDEP and maybe even prevent SUDEP. So I'd like to spend just another minute thanking my collaborators, Tim Simeone, Don Martens, Laura, and Pierce for some of the intellectual drive behind some of these studies, and then also Stephanie and Shruti for conducting a lot of the studies and analyzing the data, and then past and current lab members. I'd also like to thank our support that we've had in the lab, particularly the Cure and the Benninghoven family for supporting some of the studies I talked about here. And then finally, for the people who have lost loved ones to SUDEP that are listening, I just wanted to tell you that over the past 2 years, I'm really inspired and enthusiastic about the amount of research that has been done looking at SUDEP. And I'm very optimistic that we will be able to postpone longevity in individuals that are at high risk for SUDEP, and hopefully soon come up with a way of preventing it altogether. Thank you.
Thank you so much, Dr. Simeone, for this very intriguing presentation. And we are just on time here for our fourth presentation with Dr. Buchanan, who will speak about the circadian influences on the pathophysiology of SUDEP. And this is from the basic science perspective. You go ahead.
Great. Well, thank you, Franck. And thank you to our first three speakers. I think we've had a fantastic overview to this point. My goal here is to try to review evidence from animal models and to kind of show you some of the things that we can try to take apart using animal models that are relevant to SUDEP. I think a really important thing to appreciate is that we know a lot about SUDEP from our clinical studies and some of the preclinical studies, but we don't know everything about what happens in SUDEP in people. And for this reason, it's been challenging to come up with a single animal model that we can say is an animal model of SUDEP. But there are a lot of animal models that are relevant and useful, and I'm going to talk to you about some of those here today. In particular, I'd like to review evidence that there's influence of circadian rhythms on seizures themselves, that there's influence on relevant factors such as breathing and neurotransmitters, and that there is some influence from the animal models, we think, on seizure-related death. So we've already seen from Drs. Tomson and Thijs that there is an association with sleep and night, with many SUDEPs occurring at night and likely during sleep. We've already heard about these three specific studies, in fact. And just to show you that seizures are in fact regulated in a circadian manner. On the left, I have data, this is from humans, from Tyler Durazo at Yale. It just showed that depending on the semiology of the seizure, there may be a different circadian pattern. And this has been shown in others. It's been shown actually even in a single patient that they can have different circadian patterns if they have multiple loci. They can have different circadian patterns of their seizure of the different types. That same group, Mark Quigg's group, showed that there's a similarity between rodents who have been subjected, so rats in this case, been subjected to pilocarpine temporal lobe epilepsy protocol, and they see many more seizures during the nighttime or during the late afternoon and nighttime. And this was similar to what they had seen in mesial temporal lobe epilepsy patients. There's been quite a bit of work to show that there are circadian variations in people and in various animal models in a number of relevant factors related to SUDEP. We heard that SUDEP likely is a result of a cardiorespiratory compromise that is triggered by a seizure, and that maybe that this is progressive as we get, and we've learned that both from humans and in animal models, as Dr. Simeone just talked about. So there's circadian variations in breathing, cardiac, other autonomic, blood pressure, temperature regulation, that are all relevant factors to SUDEP. This is just to show from rats that there's circadian variation in breathing, with higher breathing during the nighttime in the rats, and this is similar in mice. And this is to show that there is circadian variation in breathing that is also regulated by sleep state. It's important to remember in the rodents, they sleep more during the daytime and less during the nighttime, but they sleep in very small bouts, and so they still are awake quite a bit during the daytime and are asleep quite a bit during the nighttime. It's just there's higher propensity to sleep during the daytime in the nocturnal rodent. Now, while we've known for quite a while that circadian rhythms influence breathing, it's never been shown before that the circadian rhythms in breathing persist in constant darkness, or that they are under control of the suprachiasmatic nucleus. In mammals, the site of the primary circadian pacemaker, two small nuclei right here at the base of the hypothalamus. So we did a little study to show that in a light-dark cycle, there is a time of day dependent variation in breathing, frequency, and ventilation, less so in tidal volume in these rodents. These are mice. And then in constant conditions, we could also discern a circadian variation in breathing. If we lesion the suprachiasmatic nucleus, so that's this described here, and we can see that we got a good lesion of the suprachiasmatic nucleus by showing that there's a loss in the nice free-running behavior rhythm. In the sham animal, it persists. Here, it's lost. We see that in the sham animal, there's a nice persistent circadian rhythm in breathing, but this is lost in the SCN lesioned animal. Now, just to switch gears for a second, circadian rhythms also regulate a number of neurotransmitters that are relevant to SUDEP. Now, here I show three: serotonin, norepinephrine, and adenosine. But there, of course, are also circadian oscillations in orexin or hypocretin that Dr. Simeone just talked about. And orexin, of course, influences these other transmitters. And so there's a very intricate, if you remember from her beautiful block diagrams, there's a very intricate relationship between all of these that I think is going to play out over time. But we see a nice circadian variation in humans and in rodents in various places of these three important neurotransmitters that have all been implicated as important in SUDEP. Now, we've heard from Dr. Simeone about these two really very nice models of SUDEP, the Dravet animal on the left and the KCNA1 null mouse, which encodes the voltage-gated potassium channel Kv1.1. And these investigators have shown that that there's a time of day dependent variation in death, with more deaths occurring in these animals during the night phase or during the dark phase. So many fewer in the Dravet animal, many fewer deaths during the daytime, and in the Kv1.1 null mouse, many fewer deaths during the daytime. Now, this is in a light-dark cycle. Light and dark, of course, can have influences on important neurotransmitters such as serotonin and melatonin. Melatonin also is relevant to seizures and epilepsy, and not formally implicated yet, I think, in SUDEP, but maybe. As Dr. Simeone mentioned, in this maximal electroshock model where we can induce seizures during any state we want, it's not a model of epilepsy, it's just a model of an acute seizure. We see many more deaths during sleep, and all every time we tried to induce a seizure during REM sleep, it was fatal. We attempted to look at time of day in this model. In this study, we did all of these seizure inductions during the daytime because it was easier. We attempted to also do these during the dark. I'm not sure what's going on there. I'm going to ignore that for a moment, I think. And we saw that in this study that we thought we saw more deaths during the light phase, which we thought made sense because this is a nocturnal rodent and they spent more time resting during the light phase. I'm going to skip that for a second. We proceeded to look at more time points to try to better describe this circadian variation. And housing animals in constant darkness, we induced seizures at every 4 hours around the clock. And we found actually that we had more deaths during the night phase. And if you look at these 2 points, these are the times that we measured in the first study. And at the top, we just see every horizontal line is an individual animal. And we look at the time that seizure was induced. And then we have sort of a loss of activity here because they were taken off the wheel. And then we see a continuation of activity in the animals that survived and loss in those that did not. In that original study, we saw that even in the non-fatal seizures, we saw more effect. We could see a time of day difference between we saw more effect on breathing and post-ictal EEG suppression during when seizures were induced during non-REM sleep. And we saw a time of day dependent difference. But of course, we have to take this with a grain of salt now because of this study. Another mouse model that's used to look at seizure-induced respiratory arrest is the DBA mouse, where you can induce an audiogenic seizure. And then these animals have a high frequency of seizure-induced respiratory arrest. Some of them can be resuscitated by putting them on a ventilator, and then they can be studied longitudinally. We attempted similarly to induce audiogenic seizures at various times around the clock, and we saw again that there were more seizures during the night phase. Interestingly, we also found that whereas these animals usually need to be primed to induce seizures, where they need to have a few audiogenic stimulations, we found that they actually had required fewer stimulations to have seizures. Now, just to demonstrate that some of these animal models have been shown to have disrupted circadian rhythms of behavior. This is the pilocarpine rat, where they have a limbic epilepsy. This is one of the Dravet models used by Dr. Kalume, just to show that they have more spikes during REM sleep and disruptive sleep architecture. And then this is the KV1.1 null mouse, just showing that they have more disrupted, they have a less clear circadian behavior rhythm, and they have disrupted sleep architecture. And interestingly, they also have, so the circadian rhythms are regulated by a very intricate molecular clock that involves many known, well-described genes. And these animal models that I just showed you have various disruptions in circadian clock genes. In particular, they looked at clock here in the pilocarpine rat. They looked at PER1 in Dravet and in clock in the KCNA1 null mouse. Now, interestingly, variations in circadian clock genes have also been found in tissue from human epilepsy patients, and that's demonstrated on top. And this is from Judy Liu's group at Brown. And when they specifically knock out clock in the pyramidal neurons, they caused a very sleep-dependent epilepsy that resulted in death. So very, very intriguing. So just to summarize, we have already heard that SUDEP occurs more commonly at night. While there are sleep state factors associated with being alone and being prone, and these are very important, undoubtedly play a role. They're much more difficult to study, of course, in the rodents. We believe that there is likely an independent role of circadian rhythms, and this may be multifactorial, involving circadian influences on breathing, cardiac activity, neurotransmitters, and genes. And we, of course, are doing our best to start to try to take apart some of these. In the rodents, we can hopefully better control sleep state and time of day and really control for these things. So I would just like to thank my current and past lab members and our funding, especially CURE for helping me get this started, and NIH for helping me keep it going. And yeah, I'll look forward to our discussion.
Thank you very much, Dr. Buchanan, for this very interesting presentation. And this time now linking all the things that we talked about, sleep disturbances and circadian rhythm and all together, and trying to understand the pathophysiology in using the animal model. And also I would like to take a moment and thank all the speakers this morning for me in on the west part of the United States, for their very wonderful and stimulating presentations. And we are now at the point where we'll open up the discussion. And please feel free and this is to the audience, feel free to send your questions in the chat box. And I think, Gordon, you okay? The alarm is going on a little bit in the background.
We've been having a lot of false positives, so I'm going to assume that this is what we got right now. And
yeah,
kick me out.
Okay, keep an eye on that. So we'll go to, I'm going to look into the chat box here and see we have a few questions already in. And I will read one of them here. Okay, and I think this is for Dr. Tomson. I think there was one person in the audience wanted to know if there was a difference between night and evening seizures, I think.
Well, I think the question was about how you define night and evening, and I think that varies from study to study. In our studies, the evening was from 10 p.m. to 6 a.m. In the Rivland study, I think it was starting slightly earlier, but the evening hours was, I think, from 6 in the Mortimer study.
Okay. All right. And then there was a follow-up question, another question, and I think this is still for you. Is the risk nearly comparable if the nocturnal seizures are myoclonic but not tonoclonic?
From our study, we actually found that the significant risk increase was seen only with the tonic-clonic seizures, be they focal from start or generalized from start. We did not see a risk increase with other seizure types, whether they are nocturnal or during daytime.
Okay, interesting.
Can I make one additional point about the nocturnal seizures as a risk factor? I think there is a possibility also that patients that have nocturnal seizure pattern have more of their seizures that go unnoticed for obvious reasons. They are unwitnessed and there's no one there. And I suspect that we underestimate the frequency of their seizures with the nocturnal pattern compared to what we underestimate with the daytime seizures.
Yeah, That's interesting. Was there anyone on the panel who wanted to make a comment? I thought I heard somebody wanted to intervene. No? Okay. Yeah. The next question is has multiple parts, and let's see how we can do this. And this is, I think this may be for Dr. Thijs, where it's talking about the first part of the question is deep sleep lowers threshold similar to if a patient take a Benadryl. And I think here the person wants to know whether you can lower SUDEP threshold by taking Benadryl.
I'm afraid I don't know this medication.
Yeah.
It's not common in our, what's the, melatonin or something?
Is it diphenhydramine? Is it diphenhydramine?
Yeah.
So diphenhydramine. So it's gonna be a first generation antihistamine.
Yeah, it's a sleep promoting medicine. So, and I think when I look at this, is that is there any correlation to medication in the case study? I think the audience wanted to know whether if you are improving sleep using medication, will that affect the risk for SUDEP? And that I think
the honest data-driven answer would be that if it promotes seizure control, then it is fine, and we are not aware of individual drugs to increase SUDEP risk. So it was very helpful, Dr. Tomson's study, to look at the effect of drugs, and if it comes to epilepsy drugs, then they are protective. And he also looked to other drug groups like SSRIs and also, but there was no effect there. As this particular case of antihistamine drugs has not been studied yet, but we have no indication.
Yeah. And do you have any comment, Dr. Simeone? Because you in part of your talk, you're talking about orexin, how it's modified the risk in the preclinical work. And what do you think about these other drugs that promote sleep? And for instance, Benadryl, I think this is what the audience.
So I think that's a fantastic question, and perhaps that's something that we could do relatively easily preclinically to see if that does have any negative impact. But in our experience, whenever we have been able to successfully improve sleep, we have also reduced seizures, and there hasn't been a change in the SUDEP probability. If anything, the longevity is increased. So we've done this with the dual orexin receptor antagonist. So suvorexant would be the one that is commonly known clinically. We've done this with a ketogenic diet, but we've also used Romaltian, so melatonin receptor agonist, and that also provided seizure control as well. So, but we have not done the diphenhydramine or the antihistamines. But based on a strictly pharmacologically speaking, if it is improving sleep based on our other data, there may be a probability of it positively influencing the seizures, but that has not been determined.
All right, thank you. And there is the next, as I said, this question has multiple folds here, 5 folds, and the next one is looking at chance there is a metabolism difference of medication during sleep. So is there something you would like to comment on that?
I just wanted to say one thing to my previous answers and any answer I have going forward. I am a basic scientist, not a clinician. So I always default to the clinicians, and I've been trained in pharmacology. So that's the limitation of my knowledge, is pharmacology and basic science.
Yeah, thank you for the disclosure. Yeah. Is there anyone has a comment on, is there any potential difference in metabolism of medication during sleep? From a basic science perspective or even clinical perspective, and Dr. Tomson?
there has been some research on circadian variation in clearance of anti-epileptic drugs, and with indications of differences. However, to translate that into a modification of the medication regime, I think, is to go too far. I saw the question, which the follow-up of the question was, should we give more anti-epileptic drugs in the late evening dose than in the morning dose? I don't think that is a good option, because what you will get with that is a variation in the drug levels over the day, which in itself is likely to be more harmful than beneficial.
Yes. Okay. Go ahead, Dr. Simeone.
And then from a basic science perspective, yeah, there is a diurnal rhythm and circadian rhythms to drug metabolism, like Dr. Tomson said, with liver enzymes. So depending on what liver enzymes the drugs are being metabolized by, they'll be affected by that. And then preclinical studies are starting to look at chronopharmacology. So, but I think we're a ways off yet. It's a new field, so it's a very interesting question.
All right. Well, thank you. And I think you guys touched the last part, where is also the person is also asking about whether to use a dermal patch to deliver the medication, and so not much is known there. And I think there was a question about why do neurologists do not discuss, I think, SUDEP more with patients and family. Yes. And this is a more clinical question, and I think it has been asked for several times in the SUDEP field. Who would like to tackle that? And I think we are opening up with more and more discussions in the field.
I think. Go ahead.
Go. No, just to start, I'm asking myself the same question. Why don't neurologists bring this up? I think we should, and I think we should do it early. And if we don't, patients will lose confidence in us and trust in us, because this information is out there. And I think it should be part of the overall counseling about risks and reduction of risks. Where SUDEP is one aspect, and there are a lot of other things that you bring up early on in the course of the patient's epilepsy. And I do think there is data to say that neurologists are much better in doing this now than they were like 10, 15, 20 years ago.
Exactly. Dr.
Yeah, I was going to say more or less the same thing. I was going to highlight that I think we're much better, and I think there's still a population of physicians that we're not reaching with our education efforts. And I know, like, all of us here talk about it that are clinicians, and all of our colleagues talk about it because we talk about the fact that we talk about it. But, all we can do is I think continue to try to reach people. So, this is maybe something for the advocates that are on the call, they kind of help us reach our other colleagues to improve discussion.
Yes, thank you very much for that insight. I was looking at the next question, which is from the audience again, and this person say that they do not have a strong background in medicine or research, and they just want to know, how do you get an animal, a rat or a mouse, to have epilepsy? That's a question. It's a very good question, and I know that when you're in the public and you wonder, how do these scientists have an animal model of epilepsy? We would like to tackle. I'll let you go ahead, Gordon.
Yeah, I can start. I'm sure we all have our thoughts on this. There's a range of ways. There's some that have spontaneous susceptibility to seizures. There's some that we induce by giving them a drug that we know will cause them to have a long seizure, and then that leads to changes in the brain. that cause them to have epilepsy. There's some genetic models where we manipulate the genes like we did with the Dravet and the KV 1.1 null model. And then those go on to have spontaneous seizures or epilepsy. And then there's a lot of induced models where we can give electricity or give a drug or give an inhaled agent. And we can look at acute seizures or sound. Sound is another way in susceptible animals. If anybody else wants to jump in, those are just some initial thoughts there.
Yeah, I think that was a good and exhaustive way of summarizing that. And I will just add that there are some models where we use it can be in epilepsy due to infection, and in that case, the animal can be presented with an infectious agent, and then that will lead to spontaneous seizures or epilepsy. And then our next question is, what effect do medication have on SUDEP? Okay, I think I'm trying to see. I think, is there any relationship, or are they medications that can modify the risk of SUDEP? I think that may be the question here from the audience.
I think Roland already answered that, but based on the study we did in Sweden, where we looked at different anti-seizure medications and the risk of SUDEP, we did not find any anti-seizure medication associated with an increased risk, whereas anti-seizure medications as such were associated with reduction in risk, and in particular duotherapy for patients with less well-controlled seizures seem to reduce the risk. So anti-seizure medications are associated with a lower risk of SUDEP, so that's one way of reducing the risk. And of course, if they make patients seizure-free, you would expect that the risk of SUDEP is minimal.
Before we run out of time for the panel, I just wanted to briefly remind people that there will be you'll be prompted for a short evaluation at the end of the webinar. So please fill that out. And then I also want to just remind people that this webinar was recorded, and it will be available for some time on the PAME YouTube channel. All right, Franck, back to you. I just want to get that in.
Oh, yes. Yeah, because we only have 3 more minutes, and probably we'll take 1 or 2 questions and before we close here. And I was looking at some of the questions that came through here. The next one, I guess probably for an advice is we have in our audience somebody who lost their brother through SUDEP, and they would like to find a way to contribute and providing the research to provide the data to the research field. And I think here what can you advise? I think I'll get this to Gordon. I think this is to go to the National SUDEP registry at NYU, is it?
Yeah, I think that's a good idea. And I think you could contact us too, and we can help you make contacts. I'd be happy to help with that.
Okay. Okay. I think this question is already answered, knowing what is the risk for SUDEP between night and day for animals. I think you touch on that, Gordon.
Yeah, I think you know, I think I highlighted the studies that we know about so far, and so in the KV 1.1 and the Dravet model, they die more during the nighttime in a light dark cycle. in the maximum electroshock seizure, where we looked at 6 points in the animals in constant darkness, we saw more deaths during the subjective nighttime. And then in the DBA mice, again, looking at the same 6 time points around the clock, in a light dark cycle, we saw more deaths during the night phase. And I think that that's, so that does tip more to the night seems to be important, you know, at least in these early studies in both the humans and in the nocturnal rodents. And so thinking about maybe some things that might be conserved between, you know, these nocturnal and diurnal species might be important. One thing that comes to mind is the, you know, the ways some of the neurotransmitters oscillate is conserved between the different species, even though one's nocturnal, one's diurnal. And then I think other things are gonna kind of come to light in the near future.
Yes. Well, okay, go ahead, Kristina.
Just wanted to say one thing in the chat box. I included a link for the SUDEP survey for any caretakers that are interested in contributing.
Excellent. Well, it seems like we reach our time. It's 10:30. Sorry, we didn't touch on all the questions in the chat box. There are many more questions, and please feel free to reach out to any of us on this panel today. And I would like to finish up with thanking our speakers and thanking the audience for the time that we shared together and this exchange of this very important issue in the SUDEP field, the connection between sleep, time of the day, and SUDEP. And we still are looking forward to more work to be done to help us unlight what is going on and how we can help patients with epilepsy who may be at risk of this type of tragic death. And thank you, everyone. And thank you to the PAME for helping us organize this very wonderful webinar.
And thanks to you, Franck, for moderating.
Yes,
Appreciate
thank you.
All right. Appreciate everyone, and you have a good rest of your day, end of your day, wherever you are.